November 1944. Field Hospital Number 7, somewhere in the Philippine jungle. Captain Elena Morrison stood in the pre-dawn darkness of the surgical tent, her hands still trembling from 16 hours of continuous operations, watching as medics carried in another wave of casualties from the front lines. Among the wounded were 3 small Filipino children, their bodies torn by shrapnel from a misdirected artillery barrage, their frightened eyes darting between the American medical staff and the Japanese prisoners of war who lay on adjacent cots. What Captain Morrison witnessed in the following hours would shatter every assumption she had carried about warfare, humanity, and the invisible lines we draw between ourselves and those we call enemies. The decision made that morning by her commanding officer, a choice that seemed to violate every military priority and tactical consideration, would reveal a truth about human dignity that transcended national allegiance and would leave Japanese medical officers questioning everything their military doctrine had taught them about American brutality and racial superiority. Before we jump back in, tell us where you're tuning in from, and if this story touches you, make sure you're subscribed, because tomorrow I've saved something extra special for you. The cultural collision that would unfold in Field Hospital Number 7 had roots extending back months before to the systematic indoctrination Japanese military medical personnel received about American attitudes toward Asian populations. Throughout their training, Japanese nurses and doctors serving in forward medical units were taught that Americans viewed all Asian peoples as racially inferior, that American medical ethics prioritized white soldiers exclusively, that wounded Japanese prisoners could expect nothing but cruelty and neglect from American captors. These teachings, reinforced through propaganda films, training manuals, and testimonials from the few Japanese soldiers who had been captured and later exchanged, created a worldview where American humanitarian gestures were impossible by definition. The framework left no room for compassion across enemy lines, no space for medical professionals to recognize shared humanity in the midst of industrial slaughter. Lieutenant Akiko Yoshida, a 28-year-old surgical nurse from Osaka who had graduated at the top of her medical training class in 1940, embodied this indoctrination completely. Captured along with 14 other medical personnel when American forces overran a Japanese field hospital in October 1944, Yoshida expected execution, or at minimum, brutal treatment that would validate everything she had been taught about American racial attitudes. Instead, she found herself transported to Field Hospital Number 7, assigned to a recovery ward, and ordered to continue providing medical care under American supervision. The cognitive dissonance between her expectations and her reality created a psychological tension she could barely process. American doctors treated her with professional courtesy. American nurses worked alongside her without the racial contempt she had been promised would define every interaction. Wounded Japanese prisoners received morphine for pain, plasma transfusions for shock, and surgical interventions that American medical staff performed with the same technical competence they brought to treating their own soldiers.
The transformation of Yoshida's understanding would not come through grand gestures or dramatic pronouncements, but through a series of small observations that accumulated over weeks until the weight of evidence could no longer be denied. She watched American surgeons operate on Japanese prisoners with the same urgency they brought to American casualties, making the same life-or-death decisions based on medical triage rather than nationality. She observed American medics change bandages on Japanese wounded with the same careful attention to preventing infection they showed their own men. She saw American nurses sit with dying Japanese soldiers during their final hours, holding their hands, offering what comfort language barriers allowed, treating their deaths as losses rather than victories. Each observation contradicted her training. Each act of basic medical humanity challenged the framework she had been given to understand the enemy. The mental architecture she had built to make sense of war was crumbling, and she did not yet know what would replace it. The crisis came on the morning of November 18, 1944, when the 3 Filipino children were carried into the surgical tent. The artillery barrage that wounded them had been American, the result of a targeting error by forward observers who had miscalculated coordinates and called in fire on a civilian area where families had been sheltering from the fighting. The children, Two girls aged 7 and 9, and a boy aged 5, had been playing near their family's makeshift shelter when the shells landed. Their parents were dead, killed instantly by the same barrage. The children survived, but barely. The older girl had shrapnel wounds across her chest and abdomen, punctured lung, probable internal bleeding. The younger girl had lost her left arm below the elbow, the limbs severed by shell fragments. The boy had severe burns across his back and legs, the kind of injuries that would require skin grafts and months of recovery if he survived at all. Captain Elena Morrison, the chief surgical officer at Field Hospital No. 7, faced a decision that would have seemed simple in peacetime, but carried enormous weight in the context of military operations during active combat. The surgical tent held 6 operating tables. 4 were currently occupied with American casualties from the same engagement that had killed the Filipino family. Soldiers with traumatic amputations, penetrating abdominal wounds, and compound fractures that required immediate orthopedic surgery. 2 tables were available. The American wounded in the recovery ward included men whose conditions might deteriorate rapidly, who might require emergency return to surgery if complications developed. Standard military medical doctrine was clear and unambiguous. Treat your own soldiers first, then Allied military personnel, then enemy prisoners if resources permit, then civilians if time and supplies allow. The 3 Filipino children, while technically civilians of a nation allied with the United States, represented the lowest priority category under normal triage protocols. Morrison looked at the children, assessed their injuries with the clinical detachment of someone who had performed battlefield triage hundreds of times, and made a decision that violated every priority her training had established. She ordered all 3 children into surgery immediately. The older girl went to the first available table, where Morrison herself would operate to repair the punctured lung and control internal bleeding.
The younger girl went to the second table, where Captain David Richardson would perform the emergency amputation revision and vascular repair needed to save her life. The burned boy would wait 20 minutes until another table became available, a delay that might cost him his life, but the alternative was letting all 3 children die while waiting for American casualties to clear surgery. The decision meant that American soldiers with serious but not immediately life-threatening injuries would wait longer for definitive surgical treatment. It meant that resources, blood plasma, morphine, surgical supplies, would be allocated to civilian children rather than held in reserve for American wounded who might need them. Lieutenant Yoshida, working in the recovery ward adjacent to the surgical tent, watched through the canvas partition as American medical staff scrambled to prepare for the pediatric surgeries. She watched nurses who had been changing dressings on American amputees drop everything and move to assist in the operating theater. She watched medics carry in additional supplies, blood plasma, pediatric-sized surgical instruments that had been packed for exactly these kinds of civilian emergencies. She watched Captain Morrison scrub for surgery with the same methodical precision she had shown hours earlier when operating on an American sergeant with a traumatic leg amputation. The cognitive dissonance intensified. Everything Yoshida had been taught insisted this could not be happening. American doctors did not prioritize Asian children over their own soldiers. American military medical doctrine did not allow resource allocation that might compromise the survival of American personnel. American racial attitudes, according to every propaganda film and training lecture she had received, precluded the kind of humanitarian gesture she was witnessing. Preparing and narrating this story took us a lot of time, so if you are enjoying it, subscribe to our channel. It means a lot to us. Now back to the story. The surgery on the older Filipino girl lasted 4 hours. Captain Morrison, working with a surgical team that had already been operating for most of the previous 18 hours, meticulously repaired the punctured lung, located and controlled 3 separate sources of internal bleeding, removed shrapnel fragments from the girl's liver and spleen, and closed the abdominal incision with careful attention to preventing infection in the tropical environment where wound complications could be fatal. The surgery was technically demanding, requiring the same level of skill Morrison would have brought to operating on a general's son or a senator's nephew.
There were no shortcuts, no compromises in technique based on the patient's nationality or social status. The only consideration was saving the child's life using every bit of medical knowledge and surgical skill Morrison possessed. When the girl was finally wheeled into recovery, her vital signs stable and her prognosis cautiously optimistic, Morrison moved immediately to check on the other two children rather than taking the rest break her exhausted body desperately needed. The younger girl survived the amputation revision surgery, though she would face a lifetime of disability and the psychological trauma of losing a limb at age 7. Captain Richardson had performed the surgery with meticulous attention to creating a residual limb that would heal properly and potentially accommodate a prosthetic device someday, thinking ahead to this child's future in ways that went far beyond immediate military necessity.
The burned boy underwent debridement surgery to remove dead tissue and prepare his wounds for skin grafting, a painful procedure that would need to be repeated multiple times over the coming weeks. His survival remained uncertain. Burns covering more than 40% of his body carried high mortality rates even with the best medical care. But American medical staff were giving him every chance modern medicine could provide. Lieutenant Yoshida watched all of this from the recovery ward, where she continued caring for Japanese prisoners of war who were themselves receiving medical treatment that contradicted everything she had been taught to expect. The Japanese lieutenant with the amputated leg, who should have been left to die according to the propaganda about American attitudes toward Asian casualties, was receiving physical therapy to help him adjust to crutches. The Japanese private with a severe abdominal wound, who should have been denied morphine as a matter of racial cruelty, was receiving adequate pain medication and careful monitoring for surgical complications. The Japanese sergeant with pneumonia, who should have been isolated and neglected, was receiving penicillin, the miracle drug that American forces were using to save lives at unprecedented rates. A drug so valuable that using it on enemy prisoners seemed to violate every principle of wartime resource allocation. The evidence accumulated relentlessly, each observation adding weight to a conclusion Yoshida was not yet ready to accept. She watched American nurses sing quietly to the burned Filipino boy during painful dressing changes, trying to distract him from agony that morphine could only partially control. She watched American medics bring extra rations to the two Filipino girls, food that came from the same supply system that fed American troops, allocated without hesitation or resentment. She watched Captain Morrison visit the children multiple times each day, checking their wounds, adjusting their medications, spending time she did not have to spare because she felt personally responsible for their well-being. These were not the actions of people who viewed Asian lives as worthless. These were not the behaviors of a military force operating under doctrines of racial superiority and systematic cruelty toward conquered peoples. The turning point came 2 weeks after the children's surgeries, when the older Filipino girl developed a post-operative infection despite all precautions. Tropical infections were a constant threat in the Philippine jungle. Bacteria thrived in the heat and humidity. Wounds that would heal cleanly in temperate climates became life-threatening in conditions where sterilization was difficult and antibiotics were precious. The girl's fever spiked to dangerous levels. Her surgical incision showed signs of dehiscence, the wound breaking down and reopening despite careful suturing. She needed another surgery to drain the infection and debride contaminated tissue, followed by aggressive antibiotic therapy using drugs that were in desperately short supply and normally reserved for American personnel whose survival had strategic military value. Captain Morrison did not hesitate. She scheduled the emergency surgery immediately, requisitioned the necessary antibiotics from the hospital's limited supply, and personally performed the operation with the same urgent precision she would have brought to saving the base commander's life. Lieutenant Yoshida, now trusted enough by American medical staff to assist in surgeries, was called into the operating theater to help.
She found herself standing across the operating table from Captain Morrison handling surgical instruments, holding retractors, watching American medical technique firsthand as Morrison worked to save a Filipino child's life while American soldiers waited in the recovery ward for elective surgeries that would improve their quality of life but were not immediately necessary for survival. The operation lasted 2 hours. Morrison drained the infection, debrided necrotic tissue, irrigated the wound with saline solution, and left drains in place to prevent fluid accumulation. The girl would need additional surgeries in the coming weeks. The wound would heal by secondary intention rather than primary closure, leaving worse scarring but giving her the best chance of survival. When Morrison finally stepped back from the operating table, Yoshida saw exhaustion etched in every line of her face, saw the toll that months of continuous combat surgery had taken on someone who should have been practicing medicine in a clean civilian hospital rather than saving lives in a jungle tent with inadequate equipment and insufficient supplies. Morrison looked across the table, made eye contact with Yoshida, and said quietly in English that Yoshida had learned to understand during her weeks of captivity. "She's somebody's daughter. She deserves every chance we can give her." That simple statement, delivered without drama or self-consciousness, crystallized something for Yoshida that had been building for weeks. The Americans were not treating the Filipino children as propaganda tools or diplomatic gestures. They were not performing humanitarian acts for external audiences or strategic advantage. They were simply doing what medical professionals do when confronted with suffering humanity, treating patients without regard to nationality or military value, because that is what medical ethics demands. The framework Yoshida had been given to understand the enemy could not accommodate this reality. American doctors were supposed to be racist and cruel, indifferent to Asian suffering, focused exclusively on supporting their own military objectives. Instead, they were exhausted professionals making impossible decisions about resource allocation while trying to save every life they could reach, enemy and ally alike, soldier and civilian together. The 3 Filipino children survived. The older girl recovered from her infection after 3 additional surgeries and 6 weeks of antibiotic therapy. The younger girl adjusted to her prosthetic arm with resilience that amazed the American medical staff who worked with her. The burned boy underwent multiple skin graft surgeries and would carry scars for life, but he lived. All 3 were eventually transferred to a Catholic mission hospital in Manila, where they would receive long-term care and hopefully find families willing to adopt war orphans. Before they left, Captain Morrison visited them one final time, bringing small gifts that soldiers had contributed, candy and drawing paper, and toys that combat troops had carried in their packs for trade with local populations. The children, still processing trauma that would shape their entire lives, smiled and laughed as American soldiers who had been killing Japanese troops hours earlier played simple games and tried to communicate across language barriers through gestures and exaggerated expressions. Lieutenant Yoshida watched this farewell from a distance, understanding now that something fundamental in her worldview had shattered beyond repair.
The Americans she had been taught to hate, the enemies her military training had dehumanized, were capable of compassion that transcended the boundaries of war. They made decisions that violated military logic in favor of humanitarian principle. They allocated precious resources to enemy civilians when those same resources might save American lives later. They treated wounded Japanese prisoners with the same medical competence they brought to their own casualties, not because propaganda demanded it or because international observers were watching, but because their understanding of medical ethics left them no other choice. Everything Yoshida had been taught was wrong. Not partially wrong or wrong in degree, but fundamentally and completely wrong about the nature of the enemy and the character of the people she had been fighting. The implications of this realization extended far beyond one field hospital or one group of wounded children. If Japanese military indoctrination had been this catastrophically wrong about American humanitarian instincts and medical ethics, what else had it been wrong about? If American racial attitudes were not what propaganda had claimed, If American military doctrine allowed for compassion and humanitarian gesture, even in the midst of total war, what did that mean about the righteousness of Japan's cause and the justifications for continuing the fight? Yoshida found herself questioning assumptions she had never thought to examine, wondering about the larger strategic picture she had been too focused on immediate medical concerns to consider, beginning to understand that wars are not just contests of military force, but clashes of competing worldviews, where the side that better understands human nature holds an advantage that superior weapons cannot overcome. The weeks following the children's departure brought a series of revelations that would fundamentally reshape Lieutenant Yoshida's understanding of warfare and the invisible architecture of belief systems that sustain military conflict. She had been given permission by American authorities to continue working in the medical ward, not as a prisoner performing forced labor, but as a medical professional whose skills were desperately needed regardless of her nationality. This arrangement, which would have been unthinkable under Japanese military doctrine that viewed captured personnel as having forfeited all honor and status, allowed Yoshida unprecedented access to observe how American military medicine functioned at the operational level. What she witnessed challenged not just her assumptions about American racial attitudes, but her entire framework for understanding how modern nations prosecute industrial warfare while attempting to maintain ethical boundaries that military necessity constantly threatens to erase. Captain Morrison had developed a quiet respect for Yoshida's medical competence, recognizing in the Japanese nurse a professional dedication that transcended national allegiance. During long nights in the surgical tent, when casualties flooded in faster than the medical staff could process them, Morrison began including Yoshida in triage decisions that required medical judgment rather than just technical skill. These conversations, conducted in halting English, supplemented by medical terminology that formed a common language between professionals trained in similar anatomical and pharmacological frameworks, revealed to Yoshida how American military medicine approached the fundamental ethical dilemmas that arise when saving one life means another person must wait, potentially dying during that delay.
Morrison explained the calculus of battlefield triage with brutal honesty. You save the patients most likely to survive with intervention. You save the patients whose survival would return them to functional status rather than permanent disability. You save the patients whose treatment required resources you actually possessed rather than resources you wished you had. These were not comfortable decisions, Morrison acknowledged, but they were necessary decisions in an environment where demand for medical care infinitely exceeded supply and where every choice carried the weight of life and death. What struck Yoshida most forcefully was that Morrison applied these same triage principles regardless of whether the patient was American, Filipino, or Japanese. The calculus did not change based on nationality. A Japanese prisoner with a survivable wound received treatment ahead of an American soldier with injuries so severe that aggressive intervention would consume resources without changing the outcome. An American soldier with minor injuries waited while a Filipino civilian with life-threatening trauma received immediate surgery. The system was not perfectly fair, Morrison acknowledged during one exhausted conversation at 3 a.m. between surgical cases. Nothing about war is fair, and anyone who tells you differently is either lying or delusional, but it was as equitable as battlefield conditions allowed. Medical ethics, Morrison insisted, did not disappear just because you were operating in a combat zone with insufficient supplies and inadequate personnel. The ethical framework became harder to maintain, required more conscious effort to uphold, demanded constant vigilance against the natural human tendency to prioritize your own group over outsiders. But abandoning those ethics entirely meant abandoning the thing that separated medical professionals from butchers with surgical training. The philosophical discussions between Morrison and Yoshida, conducted in spare moments between emergencies when both women were too exhausted to sleep but too keyed up from adrenaline to rest, revealed how completely different their military training had been regarding the treatment of enemy wounded. Yoshida described the Japanese medical doctrine she had learned,
a framework that viewed captured enemy personnel as having forfeited normal human consideration through the act of surrender, which Japanese military culture considered the ultimate dishonor. Wounded enemy soldiers were to be treated only after all Japanese wounded had received care, and then only to the extent necessary to extract military intelligence through interrogation. Morrison explained, started from a different philosophical foundation, rooted in Geneva Convention obligations that the United States had signed and was legally bound to uphold, but which extended beyond mere legal compliance into deeper ethical territory about human dignity and the limits of justified violence, even in wartime. Enemy combatants who were wounded and no longer capable of fighting were to be treated as patients rather than enemies, their medical needs addressed with the same professional competence brought to treating friendly forces. This was not just idealistic humanitarianism, Morrison emphasized, but practical policy grounded in reciprocity and long-term strategic thinking. You treated enemy wounded well because you wanted enemy forces to treat your own captured wounded well, creating incentives for both sides to maintain humanitarian standards even as they killed each other in battle. You demonstrated through actions, rather than propaganda, that your nation's values extended even to treatment of enemies, building moral authority that had strategic value in winning the support of neutral parties and occupied populations. You maintained medical ethics even under extreme conditions because losing those ethics meant losing part of your own humanity, and wars fought without any ethical constraints produced psychological damage to your own soldiers that persisted long after the fighting ended. These conversations planted seeds in Yoshida's thinking that would take months to fully germinate. Questions about whether Japanese military doctrine's emphasis on absolute loyalty and willingness to die rather than surrender actually served Japan's strategic interests, or whether it created vulnerabilities that more flexible approaches might have avoided. She began to wonder whether the contempt Japanese military culture showed toward captured personnel, the assumption that anyone who surrendered had forfeited honor and deserved whatever treatment they received, actually undermined Japanese strategic objectives by making enemy forces fight more desperately when faced with the choice between death in battle and capture by forces they had been taught would torture and murder them. She questioned whether Japanese intelligence assessments about American racial attitudes and military capabilities suffered from the same kind of ideological blinders that had caused her to completely misunderstand the character of the enemy she had been fighting. If her indoctrination had been so completely wrong about American humanitarian instincts and medical ethics, what else had Japanese military training gotten wrong about American industrial capacity, tactical flexibility, and strategic patience? The answer to that question began emerging through a series of small observations that accumulated over the winter months of 1944 and early 1945 as American forces pressed their advance through the Philippines and Japanese defensive positions crumbled despite fierce resistance. The scale of American logistics overwhelmed Yoshida's comprehension, revealing an industrial capacity so vast that it seemed almost magical to someone trained in Japanese military culture that emphasized spiritual will and tactical excellence as counterweights to material disadvantage. The American field hospital received supply deliveries every 3 days like clockwork. Trucks arriving with medical equipment, pharmaceuticals, plasma, surgical supplies, food, fuel, and replacement personnel that kept the hospital functioning at full capacity despite continuous combat operations that would have overwhelmed any Japanese medical facility within days.
When surgical instruments broke or wore out, replacements arrived in the next supply delivery. When pharmaceuticals ran low, the next shipment included double allocations to rebuild reserves. When experienced nurses rotated home after completing their tour of duty, fresh medical personnel arrived already trained and ready to integrate into existing teams without degrading operational capability. This logistical abundance stood in sharp contrast to Japanese military operations that Yoshida had witnessed before her capture. Operations characterized by chronic shortages of everything except determination and willingness to die for the emperor. Japanese field hospitals operated with inadequate surgical supplies, insufficient pharmaceuticals, barely enough food to keep medical staff functional, and no prospect of resupply once supply lines were cut by American advances. Japanese wounded often went without morphine because there simply was not enough to meet demand, receiving instead encouragement to endure pain with stoic dignity and assurances that their suffering served the emperor and the nation. Japanese medical personnel made do with improvised equipment and expired medications, stretching supplies far beyond recommended usage through desperate expedients that sometimes worked and sometimes produced tragic failures. The contrast between American abundance and Japanese scarcity revealed strategic realities that propaganda had obscured, truths about industrial capacity and logistical sustainability that determined military outcomes regardless of tactical brilliance or individual courage. Yoshida shared these observations with other Japanese prisoners in the hospital, medical personnel and wounded soldiers who were experiencing the same cognitive dissonance between propaganda and reality. These conversations, conducted in Japanese without American supervision, because Morrison trusted Yoshida not to organize escape attempts or resistance activities, revealed that Yoshida was not alone in her reassessment of everything they had been taught about the enemy and the war. A Japanese army doctor named Takahashi, captured after being wounded during the defense of Manila, described how American medics had treated his sucking chest wound with immediate interventions that saved his life despite his being an enemy combatant who had been shooting at American forces minutes before his capture. An American corpsman had sealed the chest wound with an inclusive dressing, administered morphine for pain, started an IV line for fluid replacement, and called for immediate evacuation to a field hospital where American surgeons performed thoracic surgery that gave Takahashi a chance at survival he would never have received under Japanese medical doctrine that prioritized Japanese wounded exclusively. Takahashi, a practicing surgeon before the war with a decade of medical experience, recognized professional competence when he saw it and could not reconcile the quality of care he had received as an enemy prisoner with the propaganda about American racial cruelty and contempt for Asian lives. A Japanese naval officer named Nakamura, captured when his destroyer was sunk by American naval gunfire, described how American sailors had pulled him from the ocean despite being under fire themselves, risking their own lives to rescue enemy personnel who had been trying to kill them minutes earlier. American damage control parties on the destroyer that had sunk his ship could have simply steamed away and left Japanese survivors to drown or die of exposure, which was standard Japanese naval practice when dealing with enemy survivors who represented potential intelligence sources, but also mouths to feed and bodies to guard.
Instead, American sailors had thrown life rings, launched boats, and brought Japanese survivors aboard where they received immediate medical attention, warm clothing, food, and treatment that seemed to violate every principle of military necessity and resource conservation that Japanese naval doctrine emphasized. Nakamura, like Yoshida, found his entire framework for understanding the enemy collapsing under the weight of experiences that could not be explained by the ideological narratives that had sustained Japanese military morale. These discussions among Japanese prisoners took on increasing urgency as news from the larger war filtered into the hospital through American radio broadcasts and newspapers that Japanese prisoners were allowed to read once they had been cleared through intelligence screening. The reports described American advances across the Pacific that were crushing Japanese defensive positions with overwhelming firepower and industrial superiority that made Japanese resistance ultimately futile, regardless of individual courage or tactical skill. The Philippines were falling, despite Japanese desperate defense. Iwo Jima had been taken after savage fighting that cost both sides dearly but left American forces in possession of territory that brought them closer to the Japanese home islands. Okinawa was under assault in battles that were destroying Japanese forces faster than they could be replaced. American submarines were strangling Japanese maritime logistics, sinking merchant vessels faster than Japanese shipyards could replace them, cutting off the raw materials and food imports that Japan's island economy required for survival. American strategic bombing was reducing Japanese cities to ash, killing civilians by the tens of thousands and destroying industrial capacity that could never be rebuilt given Japan's dwindling resources.
The cumulative picture that emerged from these reports suggested that Japan was not just losing battles, but losing the war in ways that made eventual defeat inevitable, regardless of how fiercely Japanese forces continued to resist. This realization forced Yoshida and other Japanese prisoners to confront uncomfortable questions about whether continued resistance served any purpose beyond prolonging suffering, and whether Japanese military leadership's insistence on fighting to the last man represented honorable determination or tragic stubbornness that would cost countless additional lives without changing the ultimate outcome. These were not questions that Japanese military culture encouraged soldiers to ask. The framework of absolute loyalty and unquestioning obedience to orders from superior officers left no room for individual judgment about strategic wisdom or tactical effectiveness. But imprisonment and exposure to alternative perspectives created space for questions that would have been unthinkable during active service. Questions about whether loyalty to abstract concepts like national honor mattered more than concrete realities like saving lives and minimizing suffering. The moral complexity of these questions intensified when news reached the hospital in early August 1945 about new weapons that had been used against Hiroshima and Nagasaki, bombs of unprecedented destructive power that had killed tens of thousands instantly and left entire cities devastated beyond anything conventional warfare had achieved. The reports, initially dismissed by Japanese prisoners as propaganda too extreme to be credible, were confirmed through multiple sources, including Japanese-language broadcasts from neutral countries that described the atomic explosions in detail that made clear this was not American exaggeration, but terrible reality. The existence of these weapons and America's willingness to use them against civilian populations changed the strategic calculus in ways that made continued Japanese resistance not just futile, but suicidal, a path that would lead to national extinction rather than honorable defeat. Within days of the Nagasaki bombing, Emperor Hirohito announced Japan's surrender in a radio broadcast that Japanese prisoners listened to with emotions ranging from relief to shame to profound confusion about what surrender meant for soldiers who had been taught that death was preferable to the dishonor of capitulation. Yoshida listened to the emperor's broadcast with tears streaming down her face, mourning for everything that had been lost and everyone who had died in service to a cause that had proven unsustainable against enemy industrial capacity and strategic resources that Japanese military planning had catastrophically underestimated. She thought about the 3 Filipino children whose lives Captain Morrison had saved by violating military priorities and allocating resources that should have gone to American soldiers. She thought about the humanitarian gestures she had witnessed over months of captivity, the medical care provided to enemy wounded without regard to nationality, the small acts of kindness that had challenged her assumptions about American character and values. She thought about the conversations with Morrison about medical ethics and the obligations professionals have to maintain humanitarian standards even under extreme conditions. And she understood something that would shape the rest of her life, that the capacity for compassion and the willingness to recognize shared humanity, even with enemies, represent strength rather than weakness, that nations and individuals who maintain ethical standards under pressure possess a kind of power that superior weapons alone cannot achieve. The war ended officially on September 2, 1945, with the surrender ceremony aboard the USS Missouri in Tokyo Bay. Yoshida and other Japanese prisoners were processed for repatriation, a bureaucratic procedure that seemed surreal after months of captivity during which the fundamental certainties that had structured their lives had been systematically dismantled by experiences that did not fit the narratives they had been given.
Yoshida returned to Japan and spent the next 4 decades building a nursing career dedicated to the principles she had learned from watching Americans treat enemy children before their own soldiers, establishing training programs that emphasized humanitarian obligations over narrow nationalism, teaching younger generations of Japanese medical professionals that their duty extended to all patients, regardless of political circumstances or national identity. She maintained correspondence with Morrison until the American captain's death in 1987, letters that documented both women's continuing efforts to apply medical ethics in contexts that constantly tested those principles, that reminded both of them about the fundamental human connections that persist even across divides of language, culture, and historical enmity. The 3 Filipino children whose lives Morrison saved went on to productive lives despite their wartime trauma, occasionally appearing in Yoshina's thoughts as reminders of what happens when professionals choose humanitarian principle over expedient calculation, when individuals refuse to allow institutional frameworks to override recognition of shared humanity. The lesson Yoshida drew from her experience and shared with anyone willing to listen was that our assumptions about enemies often blind us to realities that do not fit convenient narratives, that the capacity for compassion exists in unexpected places if we remain open to evidence that challenges our prejudices, that maintaining ethical standards under pressure requires conscious effort and institutional support, but represents the difference between warfare constrained by humanitarian principles and unlimited violence that destroys both victor and vanquished. She argued that Japan's catastrophic misreading of American character and capabilities stemmed not from lack of intelligence, but from ideological frameworks that filtered evidence to confirm existing beliefs, rather than testing those beliefs against observed reality. She insisted that the same cognitive failures that had led her to completely misunderstand the enemies who saved Filipino children's lives remained endemic in human thinking, that we are all vulnerable to believing comfortable lies rather than confronting uncomfortable truths, that the antidote requires humility about our own fallibility and willingness to update beliefs when evidence demands revision,